hard when you're doing things your way.
No, it's hard when I'm older, you know? I only got so much headspace. I told him he's giving me a wedgie in my head. All right, how are you guys tonight? Good. So Ann, and I apologize if I'm kind of standing here awkwardly, but my sciatica has really been bothering me. And the last 3 days it's really been bothering me because I've moved equipment all over the state. So I'm just kind of trying to do a little support while I'm standing here. So I kind of wedge myself into the corner here. If I go down, it's okay. I just need help up. I won't be injured.
Sit in one of those chairs. You don't have to stand up.
We might not get her out of that chair.
Yeah, I need to stand for a while, and then I might sit for a while, then I'll stand for a while, then I'll sit for a while. It actually, I thought it was on the mend, and then Monday it got worse again, so. And I have this little bit of head cold thing that's going on, so, yeah. Cut that for my grandchildren this past week, so I'm super excited.
Little petri dishes.
Yeah. Actually, they're not little, well, one of them is. My oldest one is 17, but my youngest one is 9, so I think he was a little petri dish then. Yeah. When I gave him his new dinosaur pajamas, I got lots of kisses, so. And then he called me yesterday, and he was homesick from school, and I woke up this morning, and I'm like, yeah, thanks, bud. So anyway, we're going to talk tonight a little bit about newborn care. This obviously, there's a lot more information than you can get in 2 hours, but as I looked it over, what I tried to do was look at, we start out with some risk factors of when you have to think about advanced newborn care. And when I say advanced, I don't mean necessarily ALS. I mean not your traditional position, dry position, warm, but maybe there's a little bit of ALS stuff in here, but 95% of it is BLS stuff. And this is good for 2 hours in your PDOBS category, so it's 1/4 of the time you need. So without further ado, oh dear. So just some terminology. A newborn is the first few hours of life, and then they're neonates for the first 28 days. And one of the reasons that I did want to qualify that is because when we talk about cardiac arrest events, it's a little bit different for these guys. It's not your traditional 15 to 2 for 2 people, 30 to 2 for 1. These guys are 3 to 1 in those newborn, early neonate because they so much depend. It's almost always a respiratory issue unless they have a congenital abnormality. So to think about morbidity and mortality, complications increase as birth weight decreases. Babies who weigh less than 1,500 grams, their resuscitation rate is less than 80%. So when I used to run on the NICU at Capitol for about 5 or 6 years, and we always looked at 20 weeks, 1,600 grams as viable, as something that we would consider that would possibly be viable. At Eastern Maine, any of you guys run into Eastern Maine? At Eastern Maine, when you bring a pregnant patient in, if they're having abdominal pain, if they're having bleeding, whatever it might be, they are right down to the day. If they are 19 weeks and 6 days pregnant, they go to the trauma room in the ER. If they are 20 weeks pregnant, they go upstairs. They rate down to the day. I've been subject to that. I asked the woman the day of her last menstrual, the first day of her last menstrual period. I did the math and I said, she's about 20 weeks pregnant. And they said, about 20 weeks pregnant? Is she 20 weeks in 1 day, or is she 19 weeks and 6 days? And so I went back and I did the math and I said she's 19 weeks and 6 days, and you could hear the sigh on the radio when they said, okay, we'll go to trauma 1. So babies, it's really about 20 weeks that you start looking at viability. And if you've seen, how many of you guys have seen a baby at 20 weeks, 21 weeks, 24 weeks? Yeah, I mean, those are palm of your hand babies, right? A lot of people think that it would be really cool to deliver babies pre-hospital, but when you think about delivering babies pre-hospital, those aren't the babies that you want to have to take care of outside of a hospital environment 90% of the time. You know, every once in a while, the person who couldn't make it in the snowstorm or something like that, but I always remember community ambulance. They were an ambulance out of the Etna area, and they had delivered 2 babies pre-hospital, and their ambulance was so old, they still had the stickers. You guys remember the main EMS stickers where you've got the date of birth and how much the babies weighed, and you got to stick them on the side of your ambulance. They had 2 of them, and one of their babies was 3 pounds 1 ounce, and one of their babies was 2 pounds 2 ounces. Neither one of them survived the episode. So pre-hospital babies are generally not always that exciting. I've done it 3 times, 2 times with horrible results, and 1 time with a decent result. So it can be traumatizing, you know, obviously to the parents, but also to the babies. So one of the things to think about if you have this woman in labor or you've delivered this baby, ER staff is not all that good with newborns. That's not what they do well. So what you want to do is give them an early enough heads up so when you get to the hospital you can get an escort to OB, or some hospitals. Where do you guys primarily transport to? Miles. Does Miles have any OB department at all?
Yeah.
So do they have a separate entrance? Or yeah, so like the hospital I transfer to has a completely separate entrance for OB. So what we have to do is when we have those type of patients, and we get a lot of them at Chias because of the drug stuff, is we have to take them to the OB entrance, and security has to come down and let us in through the OB. But whatever works for your particular hospital. So what are some of the risk factors? So risk factors, antepartum, so before the baby's delivered, a multi-para, so it's not their first pregnancy. There are actually more risks with multiple, pregnancies than there are, and especially if they get, it's called multi-gram para, and that's more than 5 babies. The risk factors actually become more that you may have to have some type of resuscitation with them. Inadequate prenatal care. A couple of reasons for inadequate prenatal care. Some of it's cultural. There are some cultures, some religions that don't believe in medical services, but equally, and maybe probably more what we see in the state of Maine, is socioeconomical reasons. People don't know they're pregnant, people can't afford prenatal care, either that or they don't have appropriate prenatal care, and we need to call a spade a spade. I've seen a lot of drug-addicted babies. And those are certainly, the last woman I took in labor was, had gone to the methadone clinic first and got her dose of meth, and then decided she probably ought to, not meth, but methadone, and go to the hospital. Age does make a difference. Mothers under 16 and over 35, mothers under 16 are more prone to things like eclampsia, preeclampsia, placenta abrupta, which is a complication of preeclampsia. Mothers over 35, gestational diabetes, hypertension during pregnancy, and if they've had previous incidents with babies, whether it's a morbidity incident, so the baby was born with a birth defect, the baby was a hard delivery, breech, limb presentation, shoulder dystocia, they're more likely to have that, or a stillbirth. And also miscarriages, because especially if they've had multiple miscarriages, one of the things that you want to think about, if this baby wasn't a miscarriage, I'm telling you what, that lady out there is putting some miles on. I don't know who she is, but she's been walking around this building since I got here. She has put some miles on since I got here. That's one thing to ask about, when you ask about when you're getting history, is how many times you've been pregnant, how many live births have you had, right? And if they have had multiple miscarriages, one of the things that they're researching now and looking at with women is they have maybe the miscarriages are caused due to a clotting disorder, because now multiple miscarriages are being considered a risk factor for strokes in women, even 35 years after the miscarriage. So if they have a clotting disorder, you may want to think, multiple miscarriages may mean a clotting disorder, which may mean you're going to have some complications with either mom or the baby post-delivery. Actually, post-term gestation, so they've gone longer than 40 weeks, that is actually a risk factor because of the size of the baby, gestational diabetes. With good prenatal care, we don't generally see that. They make a pretty informed decision about when they're going to induce labor or when they're going to take the baby. But if they haven't had good prenatal care, they might not even know that they've gone the full gamut of 10 months. And like we talked about, drugs, either illegal or legal drugs, prescribed medications, also have to think about fetal alcohol syndrome. mothers who didn't know they were pregnant for the first 3 or 4 months and continued to drink alcohol. That's a pretty significant time when babies can be affected. And then toxemia, which is another name for preeclampsia, hypertension during pregnancy, especially mothers who weren't treated for it, and gestational diabetes. And so those tend to make big babies, gestational diabetes do, which become hard to deliver. Oh, I'm just on a roll here. So then during labor, so premature labor, obviously we would think about there could potentially be some factors here that are going to make delivery difficult, but also the care of the newborn difficult afterwards. Meconium stained amniotic fluid. If they come out covered in lobster tamale, you probably want to think that there's going to have to be a little more resuscitation here than the normal dry them off, warm them, and position them. This was actually one of the things I had, a rupture of membrane greater than 24 hours prior to the delivery. I had a woman whose membranes had been ruptured for 48 hours. So she had a dry birth, which was bad. She was septic, which was bad. The baby was born with a big infection, which was bad. And things just really went south really, really quick. And not only that, she had a midwife who refused. It was really bad, but her membranes had been ruptured for 48 hours. Use of any type of narcotic, whether it's prescribed or not prescribed, within 4 hours of delivery, because those babies will have a lot more of it in their system. How many of you guys have dealt with a drug-addicted baby? Yeah. Yeah. But those babies are hard to take care of, and they're very subtle that they're sick. It's not an in-your-face. That's a problem with newborns. You know, I'm going to show you some deformities and stuff, but drug-addicted babies are not like that. It's the smacking of the lips or the twitching of the eyes or the just subtle body jerking that may indicate that they're addicted. Obviously, we know by now that drug-addicted babies, we leave them addicted. The worst thing we can do is reverse the effects of the narcotics on them. Any abnormal presentation, so like we talked about, there are some abnormal presentations that they say you can deliver pre-hospital. I would be very cautious about anything that wasn't head first, face down type delivery. But you know, anybody heard of babies born sunny side up, face up? Those are harder babies to deliver, and you have to worry more about airway issues with those. But those can be delivered pre-hospital. They also say that frank breech, so they have the buttocks or both feet presenting, can be pre-hospital deliveries, but don't do like somebody recently did and do an episiotomy in the field. Yeah, well, it was no problem. He'd seen it done on his wife 2 days ago. Yeah, don't do a pre-hospital episiotomy. Not recommended. Prolonged labor or precipitous delivery. And precipitous delivery is, boom, it comes out. We're actually seeing more precipitous deliveries than we used to because of the drug use. That is usually the #1 reason for a precipitous delivery. It is crack or cocaine that's been used before it. And they literally, they feel a cramp. They think they have to go to the bathroom or something, baby born in the toilet. They're in bed, they feel a cramp, think it's gas, baby born in the bed. Obviously those babies are not going to be healthy when they're delivered. Prolapse cord, so the cord's actually in front of the head, and every time the head presents, it's cutting off all circulation to the baby. How many of you guys have, I was in the NICU working in the NICU one time, and we got there just as the baby was being born. And has anybody ever seen a cut cord go bad? So the doctor cut the cord, and he didn't have it, it was a prolapse cord, but he didn't have it clamped before he cut it. And I kid you not, it was like 2 garden hoses spraying blood everywhere. Baby pulled his head back in, I was like, whoa, you know. But a significant amount of blood loss. How much blood should a mother lose during a normal delivery? Anybody know or remember from school?
It's less than a liter.
It's 500 mLs. So when you're thinking about it, a 20-ounce bottle of soda is 594 mLs. So if they've lost more than, and that's basically the way I judge it, if this looks like more than a 20-ounce bottle of soda, this is, I have to start thinking about excessive blood loss in mom. All right, which one do I want? No? I'll get it right by the end of it. So some congenital anomalies. These are all things that are pretty straightforward. Diaphragmatic hernia, That's where you can hear the stomach sounds in the lungs, and the baby's really having a hard time to breathe. Exposed abdominal contents, all these things, and I got some pictures of some of them. But these are babies who are going to need aggressive resuscitation. These aren't your normal newborn care babies. So that's a diaphragmatic hernia. So if you look, you think, how do you think that baby's going to present?
Face up.
Well, you've birthed him. The baby's already birthed.
Not gonna have good respiratory at all.
Yeah. So no chest. Oops, I forget that I don't have a pointer on this one. So he's not going to have any chest rise, right, on the side where the intestines are. And when you listen to lung sounds, you're going to hear something, but it's not going to sound anything like air moving, right? He's going to be a really cyanotic baby. Think it's going to be an easy baby to ventilate? No. And then that is a form of spinal abnormality where the actual spinal column did get closed in, the column. So these babies are going to be in significant distress when they're born, and this baby actually not only has the spinal column exposed. Can you see the meconium around it? So big risk of infection. And
would that just be a damp dressing, Sally?
Actually, you would probably want to use a dry dressing. You don't ever want to put anything wet on a baby because of the heat loss. And babies, it only takes 1 degree in the drop of temperature to make them significantly ill. So you would want to use a dry, sterile dressing and warm them as much as you can. Now the problem with this baby right here, not only do you have all those exposed contents, is it going to be easy to dry that baby? I mean, usually when we dry babies, it's over. You got to pay really close attention to not injuring those exposed, that exposed part of the thing. Exposed abdominal contents. Once again, this is sort of the same thing as a evisceration. You don't want to try to push it back in. Probably not going to be able to figure out where it goes. Just going to throw that out there. But once again, even with all these things warm, still number one thing to think about is keeping this baby warm. Then this is where corneal atresia, the nose isn't adequate for the baby to breathe out of. They're obligate nose breathers, so it's really difficult for them to breathe. Cleft palate, once again, very difficult for them to breathe, very difficult for them to nurse, which is really important for a newborn baby. One of the things that early nursing does is help with jaundice. Jaundice babies, frequent feedings, early nursings will help with prevention of that. And then obviously this baby's going to have a really hard time swallowing. This baby's going to have some airway issues with that chin that basically doesn't exist. So those, we'll talk a little bit about them, but those are babies that are going to need individualized, and we'll kind of talk about what's individual to some of them. But the basis of newborn care is always dry, dry, dry. You should use at least, and I would say if you have the little towels, you know what I mean, just the little ones, you should be using 8 to 10 of those at a minimum. I mean, literally, it's a one swipe and I'm done, because you don't want any of the wetness to go back on the baby. But each of these babies are going to be a little bit more difficult to do that to. I'm going to have a few more issues that you might get focused on. You might get focused on airway issues with this baby or the last 2 babies, but you need to think about, I've got to focus on those, but I still have to dry this baby and keep it warm. Because I can do great airway management on this baby or the babies before, but if their temperature when I get to the hospital has dropped to 95 degrees, they still have significant issues in addition to the issue they were born with. So, and then that's actually during surgery, and these babies, this is the actual surgical, so this actually isn't exposed abdominal contents. This is, they've taken the contents out of the abdomen during surgery. These are babies that may have regurgitation with blood when they initially nurse. Now, I know this is newborn care, but I think it's important to remember that some of these things, obviously, those right in your face things are diagnosed in a hospital, right? The cleft palate, the exposed spinal column, all those things. Something like that may not be diagnosed in the hospital, sometimes it takes a week to 10 days. Baby vomits, baby doesn't feel well, there starts to be blood in the vomit, doesn't feed well, starts to be blood in the vomit. So, the things that you want to think about assessing of a newborn, you know, it's gone now from this nice, warm, comfy, cozy intrauterine environment, but you do have to think about what the intrauterine environment of the baby was prior to delivery. So, if the water has broke when you got there, was it clear? Right? Was it clear in color? And what might be another question you'd want to ask? Did it have a foul smell to it? Because normal amniotic fluid does not have any foul smell to it. And that may be an indication that there was an intrauterine infection. So you have to think about intrauterine aspects of the pregnancy, as well as now it's moved out to extrauterine. When we worked in the NICU, we did pulses, both brachial and either behind the knee, posterior tibial, or dorsalis pedis on babies. We pulse oximetry, but what you shouldn't do is you shouldn't get hung up on pulse oximetry if you don't have the appropriate size. So if you don't have one of the little probes that you can wrap around their finger or wrap around their toe, pulse oximetry isn't going to be effective. The other thing, it might be subtle, and I'm not going to go into a whole bunch of reasons why, but the recommendation on a newborn baby is, especially one that you suspect they may have some compromise to it, is to take a blood pressure in all 4 extremities. We used to do both arms and both legs because there are subtle things they could pick up. Would we pick them up pre-hospital? I doubt it. But it would be good information to report if we could. Now, the caveat to that is you gotta have a newborn blood pressure cuff. You've got to have a newborn blood pressure cuff for this to be effective. But some things to think about, at the time of delivery, you should expect a healthy baby to have a respiratory rate of 30 to 60. They should have a heart rate of 100 to 180. What's the easiest way to ascertain a heart rate on a newborn? Auscultate, listen to the heart. You think you're going to count 180 beats a minute? Toby, I'm going to tap my finger. I want you to count. I want you to count every one while I'm tapping my finger, because I can't listen to that and concentrate it 180 times a minute. All I have to do is listen and tap. All Toby has to do is count, right? So I'm doing this. And the other way you can do it is if the cord is still pulsating, you can get it off the cord. You can get it off the cord if it's still pulsating. A systolic BP of 60/90, that may not be an early vital sign you take. More you're looking, are they pink in the core? We'll talk about something called acrocyanosis, which is not abnormal in babies. Are they pink in the core? If they appear to be a healthy baby, what is their 1-minute APGAR and what is their 5-minute APGAR? Those are the things we're looking for in most babies. Temperatures, you should be taking temperatures in newborns because you want to be able to report to the hospital if you delivered a pre-hospital that the baby had a temp of, and you can see normal is all the way up to 100. So if the baby had a temp of 99.9 is what you got, and he gets to the hospital and has 100, then they're not going to panic about that. If you say, we took a rectal temperature and it was 98, and now it's 99.9 or 100.1, that may be a little bit of index of suspicion for them to start thinking about, are there issues with this baby, or vice versa, the temperature dropped a lot even though we did a good job warming it and drying it. So look at the color. The color, when you look at a baby, what you really want to look at in the first 24 hours is the core. Are they pink centrally? If their hands are blue, if their feet are blue, even if it's a little way up the extremities, that is not abnormal for the first 24 hours of life. It's called acrocyanosis, and they just haven't got great circulation yet. And not only that, newborns don't have really high oxygen saturation. If you take NRP or any of those stable classes, the recommendation is newborns should only have a pulse. If you need to supplement them for some reason, is to get their pulse ox saturation to 84, 85%. No, they don't need to be saturated to 99, 100%, but which would explain if I don't have a high oxygen saturation, I might have some peripheral cyanosis. Central cyanosis is bad. If the core is blue, If the mucous membranes are pale, if the mucous membranes are dry, that's bad. But acrocyanosis, just their hands and their feet, even if it's all 4 of them, is not a life-threatening condition in a baby. And then what are their central pulses like? So what can I get? Basically in babies we usually use femoral. Really hard to get carotid, but you can. So if you are really concerned about hypoperfusion or end organ perfusion in babies, what might be a good way to get a carotid pulse? It's hard to get your fingers in there to find it. Stethoscope. Same way as, now, that still might not tell you if you can feel it or not, but at least it gives you an idea that I've got some blood going here. Femoral pulses, also a little bit harder to find, but you can put a stethoscope in there. And then capillary refill. If you're going to do, in my opinion, not only on babies, but on anybody, I'm concerned a little bit about perfusion to the periphery, but I want perfusion in my world from here to here. That's where I am concerned about perfusion for the half hour, 45 minutes, whatever I have them. Do central cap refill. Oral mucosa, do it on the sternum. That's where it's a really good idea to do it, because if I get 2 seconds or less here, I'm perfusing here. If I get 2 seconds or less here, I'm perfusing here, right? So kind of do central. You can go back and do peripheral later, but right out of the gate. In fact, most, I don't know, I won't say most, but a lot of the hospitals I've transported to or dealt with have said the things that we would really like to know if you deliver a baby pre-hospital are respiratory rate, heart rate, and core cap refill. If you can't get us a blood pressure, we're not getting our panties in a bunch about that. I don't record that, Mike. Erase that piece, edit that piece. But what we want to know is what the baby's heart rate is it over 100? Is the respiratory rate within that normal range of 30 to 60? And centrally, are they cap refilling at 2 seconds or less? All right, so APGAR. APGAR is something that we remembered for our EMT test, our AEMT test, or our paramedic test, wherever we're hanging out right now. And then it's like a lot of other things. I don't use it every single day, so I don't remember it. And I always find it a little bit confusing because Glasgow Coma Scale, you can't get a 0, but APGAR you can. So it's always a good idea to kind of think at 1 minute, what was this baby like? And then by 5 minutes, if I have a healthy baby, I've got a chance to get the book out and look at it. But the APGAR is appearance, pulse, grimace, activity, and respirations. A 0 is bad, so he's blue with no pulse, no grimace, no activity, no respirations. A 0 in a baby is bad. The ones are, so there is your peripheral cyanosis, the heart rate under 100, is a 1. The baby's grimacing but not actually making a nice healthy cry. He's kind of, see how he's kind of flexed in, not flexed out, not extended, and his respirations are weak and slow. So anything in that category is a 1. Then your 2s, your perfect score, pink all the way around, heart rate over 100. He has a good healthy cry. He's extending his extremities and or a good healthy grimace and a strong cry. And most babies live between 8 and 9. Most newborns are between 8 and 9, and most of the time the points they get off are peripheral cyanosis and maybe not a nice healthy grimace when he's first born. But the APGAR score, like I said, 1 minute is 5 minutes. If you're resuscitating a baby, don't worry about it. If you're resuscitating a baby, they're somewhere under 4. That's a good way to think about it. But they are kind of an indicator of what might be going on. We already talked about it. 9 is common, 2 on heart rate, respiratory reflexes, muscle tone, 1 on color. Score of 4 or less indicates the infant most likely will need resuscitative efforts. And a score of 4 to 6 may indicate the baby needs suctioning and oxygen therapy. So it's those ones, it's not the 0s, 1, 2s that we have to think about, or 3s. It's those babies from 4 to 6 that we have to think about what, what might we need to do to them that's not actual an arrest event. All right, 7 to 10 is a normal infant. Suction infant if needed. For those of us who took our EMT class from AAOS, the first orange book there, every baby got suctioned, right? It didn't matter. Every single baby that was born got suction. First their mouth and then their nose. Now the recommendation is only suction them if they need it. If they have a lot of secretions in their airway, if they have meconium in their airway. Because suctioning, like anything else, is not a benign process. And it can have detrimental effects. What's the number one detrimental effect of suctioning? Hypoxia. Vageling them down. And you only want to suction a newborn for about 5 seconds. That's not very long. And, you know, let's be honest. When was the last time in an adult patient you actually took the suction, measured it, taped it? I mean, when we suction, we, you know, I would say if you have to suction a newborn, measure it. If you're suctioning newborn, infants, young children, take whatever you're using for a device and measure it and put a piece of tape on it so that you don't have to measure it every single time. Because they have short airways and it doesn't take too much aggressive suctioning to make them hypoxic and to vagal them out. Both of which, you make them hypoxic and then you vagal them out and you get a significant bradycardia event in these little guys.
The APGAR score is in the protocol book too.
Yeah.
So
It's in the app.
so
we
it-
just looked it up.
So in 5 minutes, you can have someone pull them up.
Yeah, and that's what I always say. Have a general kind of memory of what they were at 1 minute, and then by 5 minutes, unless you're doing aggressive resuscitation, you should be able to do that. The other thing, from a mom perspective, and having delivered healthy babies and unhealthy babies, I will tell you what do you think the number one question, in my opinion, now this is no scientific study, but the number one question that moms will ask after are they healthy?
What is it?
What is it?
Well, generally we tell them. Time of birth. That is really important to parents, what time they were born. So just kind of take a quick look at the clock and, you know, and it not about 11:45, you know, 11:44, 11:46, but just note the time of birth because parents, you know, how many of you guys have kids? Right. Can most of you tell what time your kid was born? Can you remember? Okay. Well, it must be a female thing then, because my kid's knocking on the door at 40, and I can still tell you she's born at 12:36 a.m. You know, so yeah, maybe it's a mom thing, but time of birth. If you're not super busy resuscitating, and then these are the babies that are going to cause us some heartburn. These 4 to 6 APGARs, moderate asphyxia, so some oxygen therapy, probably gonna need to have the oropharynx suction, really efforts to keep them warm. So what is actually the best way to keep a baby warm?
Is it ambiguous stimulation?
Naked mom to naked baby. Naked mom to naked baby is actually the best way to keep them warm. If you look at the protocol, the recommendation is if you deliver a baby pre-hospital to put it on mom's chest. It gives me just shivers every single time I think of it because babies are never born when the roads are clear and dry. Babies are born on slippery roads, babies are born in snowstorms. But the best way to keep the baby warm is to give it to mom, let her put it on her bare chest, and put some type of hat on it. They lose a lot of heat out of their head. In fact, in most OB kits, they come with a hat in them anyway. And possibly some oxygen therapy, maybe just some blow-by oxygen. Just don't blow it really directly into the baby's face. You know, I know sometimes with adults when you do blow-by oxygen, it's like right here we hold it for them. But literally, oxygen supply tubing, just a little bit of blow-by oxygen for them. And then if the APGAR score remains under 7 at 5 minutes, the recommendation is to keep doing an APGAR score. So don't stop at 1 and 5. Do it at 5 again and 5 again. Oh dear. All right, 0 to 3, you've got to resuscitate them aggressively. So basically they have nothing good going on when you have a 0 to 3 APGAR. So the APGAR score though can definitely be misleading. They do not work well with preterm infants because what APGAR does is primarily measures brainstem functions, and they may not have their brainstem functions completely developed. So this little boy's APGARs were 9 and 10 at 1 and 5 minutes. There's your healthy little baby, cords cut. He's ready to rock and roll. But if the baby's obviously distressed, don't wait for 1 minute to figure out what you're going to have to do, right? 60 seconds in a newborn's life is a lot of time. 60 seconds in a newborn's life, we're going to get to the inverted triangle in a minute. You've gone through that twice because you're assessing it every 30 seconds, right? Or you've gone a third of the way down the ladder of that. So priorities in the first hour, and this is really when we have to think about when we have babies, is so do they need any type of cardiovascular assessment and support? Basically, do they have a heart rate under 60 or 80, and are we doing compression? Should we be doing compressions on them? Thermoregulation. A lot of distressed babies need a blood glucose support, so assessment and support of that. Newborns, you're looking at a 40, not a 60 like an adult. Observing urinary and meconium passage. So paying attention to urination and whether they pass the meconium. And obviously major anomalies like those ones we saw, and apparent gestational age concerns. Are they really big babies? Are they really little babies?
What's your suggestion on administering blood glucose support to a newborn, as far as
A D10.
Yeah.
D10. When I worked in the NICU, we did D12 and a half.
Yeah.
That's what we gave them. But D10 is really the recommendation. I mean, if you really had a concern, you could talk to a doctor about maybe making D5 instead of D10.
Yeah, definitely lower than baby.
And I have it later, but if memory serves me right, it's 4 mLs per kilogram is what the actual dose is. So it's not a huge dose. I mean, you remember a 5-pound baby only weighs 2.5 kilograms, so that's not very much D10. Oops, well there we go. So there's that inverted triangle of care I'm talking about. Warm the babies. The back of your ambulance needs to be warm. That's the #1 problem with birthing babies pre-hospital. We can't keep them warm enough. So if you think that in significant trauma, you're hot in the back of the ambulance, you should be really hot in the back of the ambulance if you have a brand new baby in it. If you either just birthed it or if you birthed it on the way to the hospital. You know, some of the things you can think about, if your ambulance is a walk-through and it has a door that closes between the box and the patient care compartment and the driver, shut it down. Shut that door between them. Limit the amount of times the door is open. You know, when you get to the hospital, we're not opening these doors until I'm ready to come out with this baby. Because just that one time somebody opening the door and you not being ready lets a significant amount of heat out. And then dry. I cannot emphasize that enough. You need to get the raspberry jelly and cream cheese off them, which is basically what newborn babies look like they're covered in. So don't forget, they have heads, they have armpits, they have torsos, they have creases in their legs. You need, and every single towel you use is a one-shot deal. It's like using disposable Clorox wipes. You take the towel, you dry the core, you throw it away. You take the towel, you do the core again, and I'm not saying throwing it away in the aspect of throw it away, but it goes aside until you basically want to dry till you don't have a wet towel. When you don't have a wet towel, the baby's dry enough, and now you can wrap it and put a hat on it. Possibly suction. Like I said, every baby was suctioned 10 years ago even. Now the recommendation is only suction babies who have obvious need to be suctioned. Their airway's full of fluid, their airway has meconium in it, something like that. And you may then get to the point where you actually have to stimulate the baby. Do you have to rub the baby's back? Do you have to pat the baby's feet? But those, with every single baby that's born, you are going to do warm, dry, at a minimum. Those are the two things you want to think about. You may have to position them with a blanket under their shoulders to get their airway open a little bit. Everything here, as you go down, it's less likely you're going to have to do it. May need to suction them and may need to stimulate them. But that baby who had an APGAR of 9, 1 and 5, he was a warm and dry. He was a warm and dry baby. Then, if those things don't stimulate the baby to have an adequate respiratory rate and an adequate heart rate, oxygen therapy for 30 seconds. If that doesn't work, then you have to think about ventilation, reassess in 30 seconds. If ventilation does not get the heart rate over 80, then you have to start thinking about chest compressions. 60 is with pediatric patients. With newborns, it's a heart rate of 80 that you want to be doing chest compressions. And then medications, but less than 1% of newborns actually get to needing. And really the only medication that newborns get is epinephrine. That is the medication for newborns. All right, so thinking about prior to delivery, get the environment and the equipment ready. So depending on where you are, I mean, fortunately, my deliveries have been all in residences. I haven't had one of those, I don't feel the need to push, and then on the way to the hospital, oh my gosh, I need to push, and there's a head. But get the environment ready. Never deliver a baby in a moving ambulance. I'm just gonna throw out there, dropping babies is in bad form, you know. But you know, make sure you have as clean, I would never say sterile because we can't create a sterile environment pre-hospital, but what you can have is a medically clean environment. You know, drape mom over the legs, put the drape underneath her that comes in the OB kit, pull the ambulance over if you don't have help, and you think, anytime you think you're gonna deliver, if it's just you and your partner, you need to be calling for a couple more people, because at a minimum, you're gonna have 2 patients. During delivery, like I said, if the mouth and nose needs to be suctioned, or if you need to suction, remember, always suction the mouth first, because if you suction the nose first, that can stimulate the, and anything that's in there can go in their lungs, and newborn babies die of aspiration pneumonia. That's really hard on them. And it, like I said, if the amniotic fluid breaks and you see it, you want to note the color, you want to note the consistency, and you want to note the smell. If it doesn't, that's one question you want to ask mom. A foul smell to the amniotic fluid should be your first indicator that there's something wrong. Or if she says it wasn't clear, an indicator, holy moly, we probably are going to have some issues here when and if we deliver this baby. Oops. So temperature. Babies can't.
Can you back up one?
Oh.
Because I can't you.
No, I can.
Well, no, you don't have to. You said, it said prior delivery, prepare environment, delivery, suction mouth and head. Okay. Are we still, I learned this a long time ago, are we still, as soon as the head produces, stopping, doing the bulb syringe?
No, only if you see an indication. You can slow the delivery down a little bit just to get in the right position. But suctioning only happens if there's an indication you need to suction.
I've heard you say that, so I didn't know whether, we used to stop.
We used to stop, yeah.
And then continue the
yeah.
Yeah, okay. That's all I got.
Perfect. So yes, I can. I've just lost my regular remote and I haven't had time to go to the store to get a new one. So every newborn has difficulty with a cold. They have no thermal regulation mechanisms in place yet. So dry, warm, you know, if you think about warm blankets, one of the things I did is I put them up front on the heat, on the defrost, until I got ready to use them. But don't use any type of chemical hot packs on them. You may, if you've been involved in like where a NICU team came and picked a baby up, they may have something like that, but it's very different from what we carry in the back of the ambulance when you go like this. So babies have very thin skin and they burn very easily, and it would be very easy to burn them with a chemical hot pack. So, you know, don't use like the fluid from your IV warmer. You know, if you've got IV warm and you've got IV bags, that's not recommended. It's blankets. Mom, that's what's recommended to keep baby warm. Hat on the head.
At some point in the one that I actually did, we ended up putting the baby between mommy's legs. I just, you know, because we were so scared we couldn't see straight.
You're not just kidding.
But that seemed to be, the baby was right there and we kept it warm, and the baby was protected. And, you know, that, and it seemed at the time, I think I vaguely remembered somebody saying that's not a bad place to put them.
No, I guess I wouldn't disagree. You know, it's still, there's some skin-to-skin contact there. The only thing I would be worried about is mom getting cold, and it would be a little harder to monitor a baby that was,
yeah.
You know, and I'm not saying it's wrong, because I never played Monday morning quarterback. Everybody does what they have to do for the situation they're in. You know, that I don't think it's a horrible idea. I wouldn't look at you and say, really? No. I mean, if that's what kept the baby warm and that's where you felt the safest place to put the baby and transport the baby was, there you go.
I would think going back to your clean environment, that would be a hard place to keep clean
Yeah,
post birth, but maybe.
But on the flip side of that, and I absolutely 100% agree with you, but on the flip side of that, baby's not being exposed to anything it wasn't already exposed to.
That's true.
Mom's bleeding, the placenta. The only thing that I'd be worried about is placental delivery.
Yeah,
If the placenta delivered and we weren't paying attention and that plops out on the baby.
I've tried to block that whole episode.
Towels.
People laugh.
Yeah.
We may have put them on the, but I seem to remember we put them, we just left them, you know, clamped cord.
Yeah, so my question is, did you leave them there until the cord was cut? Or is that
I
where you
didn't cut the
left
cord,
them?
clamped
You didn't cut the cord? Okay. So I'm not really talking about delivery, I'm talking about newborn care, but that does warrant mentioning. Until the cord is cut and clamped, the baby has to be at the vaginal level or below. So if the cord is still attached to the placenta, it's a boy, is a really bad idea. Because every bit of blood that's in that baby is going to drain back through the cord into the placenta. So until the cord is clamped, and if it's clamped, that's okay, or clamped and cut, it needs to stay at the level of the vagina or below, so that it's not gravity draining it out. The other thing that warrants mentioning, because I actually, once again, when I worked on the NICU, one of the nurses that worked on the NICU told me about this. During one of their rotations in a bigger hospital, didn't happen here in Maine, that we've all been taught, but I'm going to mention it again, never ever ever pull on babies being delivered in those difficult deliveries. It has happened where they have caused internal decapitation by pulling on the baby's head. Don't pull on babies. All right. If the position for them is on their back, maybe a little bit Trendelenburg, but once again, these are compromised babies. These are babies with those APGARs of 4 to 6. This isn't your healthy 9 on 9, you know, at 1 in 5 newborn. You might need to put a towel under the shoulders to position it a little bit, but what you also want to do is avoid neck underextension and overextension. And I'm not sure how much this way and this way to close off the airway, but it's kind of a reference. In a pediatric patient, it is less than 1 millimeter of swelling, so that could, you kind of equate it to that, causes a 50% cross reduction size in the trachea. So it doesn't take, how many of you guys have done CPR with the babies that have the pink stripes on them? You know what I'm talking about, babies that have the pink stripes on them? What happens, because they have that visible trachea, what happens when the head goes back too far? You can see it, you can see the trachea collapse, right? So that kind of neutral inline sniffing position. And if the secretions are really heavy in a baby, place them on the left side. That's the easiest position for babies to help gravity drain secretions. If you need to suction, bulb syringe is what you want to use, but you still want to measure it. You can go in too far with a bulb syringe. A bulb syringe, even those little ones, you can go in too far, especially if you're talking about preterm or small birth weight babies. As I said, mouth first, then nose if indicated, because neonates are obligate nasal breathers. That's where they want to breathe. How many of you guys have had a kid with RSV or bronchiolitis, and when you got there, they were in significant respiratory distress, and then you suction their nose, and all kinds of ooby-goobies came out? I had a kid once who had a respiratory rate of about 96, 98. Suctioned his nose once, and it dropped his rate to like 64. Just suctioning both nares, getting the stuff out of there. They really work. Yeah, no doubt. Yeah. Crying babies are good babies. Good babies. You really want to pay attention to bradycardia if you're suctioning, especially if you're doing frequent suctioning. One of the common causes of bradycardia in newborn children, and meconium. Now, babies can be meconium stained, so they can have meconium on them and not have it in the airway. So you need to visually inspect the airway. You know, maybe they just started, the head was already delivered when they started to have the bowel movement. Meconium in uterine means there was some type of distress there, but maybe the actual process of my head coming out, my lungs being squeezed and pushed all that fluid out of there, might have made me poop a little bit, you know? Birthing is not easy on anybody involved, whether it's the EMS provider, whether it's the mom, or whether it's the actual baby itself.
Did you poop a little?
What?
I pooped a lot.
Is that
It
like,
wasn't funny.
honey, can you bring me an extra pair of underwear to the hospital?
It's not even funny today.
No. The one that I had, actually I've had two that were good I liked. One was born in my driveway. Literally, that's what happens when you live in a small town. It was a snowstorm. They were on their way to the hospital. The late contractions got worse. They knew where I lived, and they pulled in my driveway. And I kid you not, I get a phone call from the dispatcher, and they says, hey, you've got delivery in process. You need to, and I'm like, they're headed for the hospital, and I said, keep them headed for the hospital. I can't get to the ambulance, because at night we stay home. Can't get to the ambulance. Get back to them quicker than they can get to the hospital. And the dispatcher said to me, look out your window. And there they were with the four-way flashers going. But yeah, and then one born at a residence, again, both of them were in snowstorms. But you didn't see any tamale on them. Now, the other problem is, if this baby has any openings, so some of those congenital anomalies we saw, the meconium is also super bad for that. So if you get to the point where you actually do have to do tactile stimulation on them, so we've warmed them, we've dried them, we've positioned them, and we've suctioned them. So then it's, do I need to do some tactile stimulation to increase the baby's respiratory and heart rate? When I say flip the soles of their feet, that's what the terminology is, and I left it up there because I wanted to remember to go back to it. So flicking the soles of their feet put even pressure on their feet. So don't do this. Why don't you want to do this? Does anybody know? Well, okay. But the other thing is, it doesn't make a nice even pressure, and it's a sharper pressure. And if babies are compromised, blood draws almost always come from their feet. They have little teeny tiny needles they use with little teeny tiny tubes, and that's where, and when you do this, it tends to break vessels in their feet. Even pressure does not break vessels. So even in little ones that you suspect might be, so now maybe they're a little bit older, get called for a 3 or 4 month old baby not breathing, do this as opposed to this on the bottom of their feet, because a lot of times that's not only where they draw blood from, but those are the best access spots. Or stroking their back, but don't hold them upside down and shake them. Okay. Those days are over. They ended with Little House on the Prairie.
If you watch them in the hospital, when they are drying them, they're really aggressively drying them.
Yeah.
Like in that.
Vigorous drying, it's called.
And that was taught to me like that was some sort of stimulation. You're stimulating,
Yeah.
you're doing both. You're drying and stimulating, which is.
Yeah, and when I think about it, most of the time at EMS we're doing that anyway, because we're not really washing our towels with Downy and all that stuff.
Yeah.
Our towels in the ambulance are pretty rough, and that's why I say a towel is better initially, especially in a baby that's not 8 or a 9 on the APGAR, because bath blankets are soft. You can use bath blankets, but they have a couple of disadvantages. They don't absorb like a towel does, and they don't provide the stimulation that like a terry cloth towel does. So if babies have, remember these are babies that are compromised, evaluate respirations, and then if they have spontaneous, look at the heart rate. If they have absence or gasping respirations, brief tactile stimulation. Brief tactile stimulation, and then positive pressure ventilation with 100% oxygen for 15 to 30 seconds. The really important thing to remember there is it's got to be the appropriate sized equipment. Got to be the appropriate sized equipment. If the heart rate is above 100, look at the color. If it's below 60, continue with positive pressure ventilations and then initiate compressions. And that triangle, everything is in a 30-second block. So if at the end of 30 seconds, the warming, the drying, the tactile stimulation, the positioning, the suction hasn't stimulated this baby to increase its heart rate, increase its respiratory rate, then that's when I go to oxygen. If that doesn't stimulate it, after 30 seconds, then I'm going to look at respiratory. Do I need to positive pressure ventilation? I do positive pressure ventilation for 30 seconds. Doesn't bring the heart rate above 60. Then I'm going to go to chest compressions. What's the compression to ventilation rate in a newborn baby?
You said 3 to 1.
3 to 1. 3 compressions, 1 breath. So, and newborns, really the recommendation is always to have 2 people because it's really hard to do 3 to 1 with 1 person. 1, 2, 3, 1. 1, 2, 3, 1. Your target number is to get 120 events in 1 minute. So in 60 seconds, I want to do 120 between of the cycle 4. 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe. So it really is a 2-person, and that's why calling for help early is so important in these cases. Mom may have the best prenatal history, the best prenatal care in the world, but anything can go wrong at any time. Remember, the majority of babies are born healthy. We birth them every single day, healthy babies. But what you don't want to be is a guy with your pants, caught with your pants down because mom had good prenatal care, mom took vitamins, mom denies any drug use. This is going to be a normal, healthy delivery. Baby comes out, baby's compromised. Oh, and by the way, mom's losing blood, right? You are in a heck of a situation because basically what you now are stuck on scene until you can get extra hands. So if you have any indication at all that delivery is imminent or you're dealing with childbirth, get extra help on the way, and if you don't need it, thank you very much. I'll buy you a cup of coffee tomorrow.
The sad, unfortunate part of it is that most of those babies that are healthy and normal are born in a hospital.
Yeah, exactly.
And if they're going to be sick, they're going to be sick.
Right, like I said, every once in a while you get the luck of the draw. It was a snowstorm. It was, my 3rd baby, and I thought I had time to get to the hospital. But the majority of pre-hospital babies are sick babies. They're not 9 and 10 on the APGAR score. They're not. So if the heart rate is between 160 and between 60 and 100, and not increasing, continue with oxygen by positive pressure ventilation. Initiate compressions. After 30 seconds, reevaluate. If it gets up to over 80, you can discontinue compressions. Oh dear, what did I do there?
In summary,
Yeah. Oh, look. All right. If they have central cyanosis, free flow oxygen, when pink gradually remove it. If no improvement and their color centrally doesn't improve, consider positive pressure ventilations. If they have acrocyanosis, observe and monitor them. You don't need to do anything for acrocyanosis and an otherwise healthy newborn. So meconium is a risk factor in about 10 to 15% of all deliveries. Some of the things that you want to think about, baby is in fetal distress, that's why they have meconium. The other thing is when you're ascertaining where mom is in the pregnancy, babies over 40 weeks of gestation are more likely to have meconium. They're more likely to have stress when they're born, so you want to think about that. If she says, my due date was a week ago, meconium kind of wants to go a little bit higher on your list. Complications from meconium, obviously, they'll get hypoxic, especially if they get in their airway. Big thing for meconium, aspiration pneumonia. That's why it's so important. If there's meconium in the mouth, always suction the mouth first, because if you suction the nose first, it's all it's going to take to get, and it's not, doesn't need to think about, those lungs are probably that big, literally. It's not going to take much of that tamale down in there to cause them to have an aspiration pneumonia. Also meconium, depending on if they aspirate it, what else is going on, you want to think the babies might have a pneumothorax. Now, are you going to decompress a pneumothorax in a newborn? Probably not. I've done it once on the NICU, and probably the scariest thing I ever did. That's why we had paramedics on the NICU, because nurses couldn't decompress, but paramedics could in our scope of practice. And there's nothing, if you read your scope of practice, there's nothing that says you can't decompress a newborn. Little teeny tiny butterfly needle, and we did it based on x-rays. We did not do it based on lung sounds, because you can't get good lung sounds in a newborn. You've got the heartbeat, the heart's just racing. But a complication of meconium can be a pneumothorax and also a pulmonary hypertension. You're not going to do anything about that pre-hospital. It's just things to think about when you have a meconium-stained baby. to monitor it, to pay attention to what's going on. You're never going to be able to figure out pre-hospital if they have pulmonary hypertension. You just can't.
How necrotic is meconium?
It's not necrotic.
Not necrotic?
Nope. The only internally aspiration pneumonia, but on their skin, not necrotic. All right. In a depressed infant that has meconium, until you can get the airway cleaned out, do not stimulate them. Now, the best way to stimulate them is tracheal suction under direct visualization. So
Laryngoscope?
thank you. Laryngoscope and blade, and use the meconium aspirator to suction them. What's the problem if it's a distressed infant and you haven't stimulated them? Anybody know? Cords haven't opened. Cords don't open until the baby takes their first breath or they cry, right? So it's really hard. If you've ever looked at the cords in a baby, they are not very big, right? And when they're closed up, there's a pucker factor of that big, but that is what you want to think about. And your endpoints would be that the infant breathes on its own, the airway's clear, that it doesn't become bradycardic, and if it does become bradycardic and after you've suctioned the meconium out, go to ventilation. The number one cause of bradycardia in newborn babies is hypoxia. Anytime a baby is bradycardic, the first thing you want to think about is either passive oxygen therapy or positive pressure ventilation. All right, that's just a picture of meconium aspirator. Do you guys actually keep those on the truck? Yeah.
Yep.
Yeah. Do you have it like a PD? Okay. And so bradycardia, the possible causes, the things you want to think about in the pre-hospital environment are hypoxia first. Do I need oxygen therapy? Do I need positive pressure ventilation? Also, just like in adults, increased intracranial pressure can cause bradycardia in babies. We're not going to fix that pre-hospital. The only thing we're going to do is ventilate them. And even their end-tidal CO2s, low 30s, end-tidal CO2 in these babies if we're ventilating them. Hypothyroidism, you are not going to do that in the back of your mouth. Acidosis, not super common but not uncommon, diabetic mother type issue. And bradycardia really has a minimal risk if corrected quickly. What's the number one cause of bradycardia in babies? Hypoxia. How do we correct hypoxia? Oxygen therapy. So that's what you want to think about. If the baby's bradycardic, assume it's hypoxia because you can fix that. Then if it's not fixing it, maybe some other thought process will come into your head, but they're not anything there that we're going to fix in a pre-hospital environment. Look at the upper airway for an obstruction. Now they say foreign object. I'm not really sure what foreign object got into a newborn baby's mouth, but you should think about it. Are there secretions or cleft palate babies? The Robin-Pierre syndrome babies, those babies, they may have a soft tissue obstruction in the upper airway. And they also might be hypoventilating, not breathing 30 to 60 times a minute, which stimulation might fix. Once again, management position and suction if their heart rate is less than 100. Then BVM with O2 and reassess, heart rate less than 60. Chest compressions and reassess, 60 to 80, but it's not improving. So between 60 to 80 is kind of a gray area. You kind of now have to use some assessment skills. Is the baby improving enough that oxygen therapy or ventilation is going to work, or should I continue doing compressions? But you still have to keep the baby warm. You still have to keep the baby warm. So you still should have something on its head. It still should have something under its back. You could still have this half of the body wrapped, right? If you're doing compressions ventilation, you don't need from here down. You need here and you need here, right? So you still shouldn't have them. Remember, we're not a hospital with an incubator. We don't have lights that we can put on them. The fluorescent light on your action area is not going to accomplish it. I'm just going to throw that out there. And I say this because it's been tried. So you still got to keep them covered from here down. And babies like to be wrapped, so keep them covered. All right, when the heart rate gets over 100, discontinue chest compressions, reevaluate for oxygen therapy. Preemies, it used to be 35 weeks now is actually born before 37 weeks of gestation is considered a preemie. It's also considered weight less than 2.2 kilograms. Now, some of the new literature actually says under 5 pounds is considered a premature infant. And like I said, they start considering fetuses viable 23 to 24, but at 20, if a woman is showing signs of active labor or has vaginal bleeding, at 20 weeks of gestation, they will become an OB patient, not an ER patient. So premature infants, there are all kinds of things that can go wrong. They can have respiratory suppression, head or brain injury. Their bones were not ready to be pushed through the birth canal. The birth canal is a very traumatic experience for a newborn. Temperature regulation. So babies develop something called brown fat at about 8 months of gestation, and brown fat is what keeps them warm. If they are under 8 months of gestation, they do not have brown fat, so they even have less ability to keep themselves warm than a baby born after 8 months. Blood pressure fluctuations, hypoxemia. They could have intraventricular hemorrhage, cerebrally, and then fluctuations in serum osmolarity, but we're not going to know that pre-hospital. But those are some of the complications they can have. So premature infants, they look different physically than a term baby. Their trunk is larger in proportion to their extremities because of the way they've developed in utero. Their skin is thinner. They're not wrinkly like like newborn babies. You have, I always say, 3 rolls of fat masquerading as an arm. They don't have that in the premature, and they also, like I said, less subcutaneous fat and less brown fat. So obviously there, significant difference in the way those babies present, not just in their size, but just look at their proportions. How their trunk is proportioned to their extremities, how their head is proportioned to their bodies, how they're positioned, right? What are these guys doing? That's not an Apgar of 2, right? This one on the end has that Apgar of 2. And once again, look at the difference in the resting positions. These are all, obviously hospital babies, preemies, not preemie. Just look in the, you can really tell the difference in their positioning. In a premature baby, they just don't have the muscle control. They don't have the ability to do that yet. But once again, that's brainstem function, the one on the end. So management is the same with a full-term newborn. You still are going to go through your inverted triangle, always start at the top. Now, transport to your appropriate facility. That becomes a little complicated in Maine. But how far are you guys from Maine Med as opposed to Miles? I am geographically challenged.
It's 55 miles.
55 miles from Miles,
Yeah,
and it's 65 for us.
An hour.
Yeah. So,
45
you'd still be taking this baby into Miles, right?
Yeah.
You'd still be taking this baby into Miles because even if it's either NICU team's gonna come down, or nurse and a doc are hopping on board, right?
Maybe.
So, yeah.
It's happened, but
Yeah. Do you guys have pretty good luck with the NICU team down here? But at Miles, do you have a lot of NICU transports out of there?
no, Barbara Bush comes out to get some.
Yeah, that's what I mean, Barbara Bush. Do they?
We take mom out, take mom later.
Yeah. We see you guys have Angel 1 and 2 down here, and we have Miracle in the other direction. We probably see the Miracle come to Machias, I'm going to guess, at least once a week. At least once a week is making a trip down. A lot of depressed babies. So the most common cause of respiratory distress or cyanosis is prematurity, the most common factor. Babies who are less than 30 weeks of gestation or less than 2 pounds and 10 ounces really have difficulty. Lungs just have not developed at all to be adequate. Most of these babies, they're missing surfactant, the WD-40 of the alveoli. These babies don't have that. And now, if you get an opportunity, and not that I would ever wish a premature baby on anyone, because I wouldn't, but if you get an opportunity to see surfactant administered ever, take them up on it. Watch them do it. Have you seen them do it before? So surfactant literally is WD-40 of the alveoli. That's the only way I can describe it. These babies are basically born with dry alveoli. There's nothing there to, there's no, the friction won't let them work. There's nothing there to smooth it by. When they give babies surfactant, I had never seen it until I did my NICU rotations, and they literally, they give it a dose and then they kind of put it this way. They give it a dose and they kind of put it this way. They give it a dose and they kind of put it this way and they give it a dose. All I can think of is they're trying to gently shake the baby up and move all that around. Did you see it when you were in NICU, when you did your stuff, Toby? Yeah, it's really, if you get a chance to watch it, you'd be like, all I can think of is, we don't want to give this kid shaken baby syndrome, but we're trying to get that all through their alveoli. So they give them a little bit, change the position. Give them a little bit, change the position.
It's like coating a frying pan.
Yeah, yeah, exactly. That's a good analogy. I'm stealing that from you.
Are they just putting it ET? They're doing it that way?
Yep. Yep, they're doing it through an endotracheal tube, and they just, it's a really expensive medication. I think it's a refrigerated medication, if I remember correctly. It can only be out of the refrigerator for so long. Because I think we used to have to take it in a cooler if we went to like Presque Isle, Caribou, those places. But yeah, they just put little tiny doses in, like, and Toby, that's a great analogy, like coating a frying pan. Got to shake it around and get it all around down over there.
Well, after the initial dose, does the body just sort of take over?
Hopefully that's going to stay with them. The body's going to start to produce surfactant. But I have seen, now, I did NICU transports. I had to do some rotation in the clinical, but I was the paramedic on the NICU team. So generally, I got to see it given in the sending hospital, and it lasted long enough. I don't know if in the once they got them back to Eastern Maine, if they had to give them more doses. I never, when I was up there, because we had to do so many clinical hours a month if we didn't go on transports, I never saw them dose babies a subsequent time, but I do not know the answer to that
It just seems
definitively.
like physiologically the body would have to take over at some point
Yeah.
and create its own, or else they run out again.
Yeah.
I mean,
Yeah, so, but I don't know if they do run out, and it could be, like the door hinge that you have to spray every so often. Multiple gestations tend to result in lower birth weight babies, so you want to be, think about the possibility of respiratory distress in those babies, as do prenatal maternal complications, so mom had some type of complication, and maybe not only with this baby, but prior pregnancies. So if mom says, something wasn't right with this pregnancy or something wasn't right with prior pregnancies, you want to think a little bit about respiratory distress. So some of the things that cause it, immature control of the respiratory center, easily affected by environmental or metabolic changes, lung or heart disease, meconium babies who aspirated, babies, remember premature babies especially, they can't take that. When one of the reasons when you see a vaginal birth as opposed to a C-section babies are pretty, right? They are pretty, they don't have the cone-shaped head, but they're also a little more prone to respiratory distress because the actual act of birth, squeezing down through the birth canal, remember the lungs have fluid in them. The lungs haven't done anything until they squeeze down through the birth canal and pushes that fluid out. But another one that causes respiratory distress, keep thinking that's a laser pointer and it's not, that causes respiratory distress, sepsis. Babies who had babies can be born septic. They don't have to have a period of time to develop it. If mom had some type of intrauterine infection, sepsis, and when you think about the adult septic patient, what's one of your earliest indicators, or shock? Increased respiratory rate, respiratory distress. So they may be tachypnic, they may have paradoxal breathing, they may have periodic breathing, like it looks like Cheyne-Stokes, where they don't have a regular respiratory pattern. Intercostal retractions, and as these go down, they kind of get worse and worse. Grunting. Grunting is bad. Grunting is really, really bad. I heard a mother say once, "Oh, isn't that cute? He sounds just like a little baby pig." And I'm thinking, if you knew what that meant, you would not think it's cute. Why do babies grunt?
Trying to clear stuff out of there.
Alveoli are completely collapsed. They're trying to self-peep. So think about the emphysema patient. What's he doing when he breathes, right? Well, babies, when they grunt, they're doing the same thing. It's a physiological response to collapsed alveoli. So if they have collapsed alveoli, they are not efficiently exchanging gas. And the louder the grunting, worse it is. And then those respiratory rates greater than 60, respiratory rates even in infants greater than 60 are danger, danger, Will Robbins. Because they're breathing faster than once a second, they're not blowing off CO2. And even infants have to blow off CO2 or they're going to become acidotic and they're going to decompensate pretty quickly. And heart rates, you may find them greater than 160, less than 110, and when they start to get down under 100, then down to 80, you've got to start thinking about doing compressions in these babies. So once again, it is airway, breathing. Do I need to position them? Do I need to suction them? Do I need high flow O2? Do I need positive pressure ventilations? Is this a baby that needs to be intubated? Now, intubation is a last-ditch effort because intubated babies will be in the hospital longer. Anybody who's intubated, especially pediatric patients, you want to try to avoid it. But if you can't, what you don't want to do is avoid it so long that you can't make up for the fact that you didn't do it early. It's a balancing act. I have to tell you, if I had one of these kids in the back of my ambulance, I'd be on the phone with it. I would be on the phone with an ER saying, this is what I have. Is the pediatrician in, or where do I go from here? Do you want me to intubate, or, you know? And a lot of people say, well, I'm a paramedic, you're supposed to know that. There's no shame in knowledge sharing. There's absolutely no shame in knowledge sharing, and there's no shame in asking questions. I know the ER doctor went to school a lot longer than I did. I also know that he gets a comma in his paycheck every single week. He gets paid once a week and it comes with a comma, right? So there's no shame, no harm in saying, I need a consultation. These are high stress situations. And just that fact of having that other voice on the phone probably takes my pulse rate from 140 down to maybe 120, right? Because remember, when my pulse rate used to be 140, 150, I'm not functioning quite as well either. Oh, did I go backwards?
Jumped on,
Oh, it did? Yeah, I need to make time. But remember, still got to keep them warm. No matter what these problems are, you've got to keep these babies warm. And the sicker they are, the more important it is to keep them warm, which I know for us in EMS, that's counterintuitive. We want everybody naked so we can see what's going on and to make it easy to work for them. But you got to make a conscientious effort. The baby's wrapped, the head is covered. I'm only exposing the part of the body I need. And the heat is so hot in the back of this truck that I'm going to need Zofran when I get to the ER because my nausea level is right here. Jaundice. Jaundice is a yellow coloring of infant skin. It's caused by the natural breakdown of red blood cells in an infant after birth, but it's never considered normal in the first 24 hours. Jaundice babies generally don't jaundice until after they're 24 hours old, when the red blood cells start to break down. So it usually peaks between 48 and 72 hours and disappears within a week. It's usually benign. For those of you who've either had a jaundice baby or know someone who had a jaundice baby, they go in quite frequently to have their bilirubin tested, and then if it becomes a concern, they go under Billy Lights to take care of that. But there are also some things beyond, you know, if you have a newborn who's jaundiced, early and frequent feeding, neutral thermal environment, so they're kept at the temperature they were born in, and also think about hypoglycemia. Jaundice babies will get hypoglycemic a little bit quicker, and hypoxia. Hypoxia it's breaking down of red blood cells. Seizures are very rare in newborns, but the problem is they're also very subtle. How many of you guys have seen a newborn baby seize? It is so subtle. It was early in my career when I was an EMT, and we had to take a baby from Machias to Ellsworth because DHS had taken custody of it, and they didn't want the baby staying in the Machias hospital. Either hospital could equally take care of it, but the parents were in Machias and they just didn't want all the legal stuff. So we put the baby in an incubator. We took a OB nurse with us, and she really explained, it was really nice, she really explained a lot to me. I never, ever, as an EMS provider, would have realized that this baby was having significant seizures. Eye flutters, a little bit of lip moving, you know. So the problem is, it's not that tonic-clonic. I realize that we've got some anoxia going on, but in these guys, they can get anoxic with those seizure-like symptoms as quickly as the rest of us can with tonic-clonic. This baby actually went on a Valium drip. It was a newborn baby that was on it was a drug-addicted baby.
Must have to be careful with the respiratory drive.
Yeah.
With your Versed and that
Yeah,
kind of stuff.
yep. Tonic-clonic seizures typically don't clear. Like I said, eye deviation, blinking, sucking, that was it. They weren't hungry, that's what this baby was doing the whole way up. And that's actually what brought the conversation up. I said something about, can we feed the baby? Does the baby need pacifiers? And she said, no, that's the baby seizing. That's what's going on right now. That baby is seizing. I was like, oh, I wouldn't know that. They make kind of swimming movements because remember they just kind of like this. Maybe changes in color. That periodic breathing you might want to think about is a seizure. And if they do have tonic-clonics, more common in preemies and indicative a lot of times of intraventricular hemorrhage. They have some type of bleed in the brain, which makes sense. Increase in intracranial pressure causing seizures. They can have focal clonics, they can have multifocal myoclonics, but most of the time you can't see it. Why might they have them? If you kind of look, or kind of looking, same things that happen with babies. Are they hypoglycemic? Do they have sepsis? Are they febrile? An infection? What was a history you got from mom? Developmental abnormalities, but drug withdrawal. Drug withdrawal probably is the most common reason I've seen for babies seizing. So the problem is you can't treat them for that drug withdrawal. You have to treat them for the symptoms they have. You cannot give Narcan to a newborn or a neonate.
Just imagine.
Yeah, it's going to make a bad situation 100 times worse.
What's the time frame, Sally, from just pre-delivery to delivery that they're going to have the significant withdrawals? I mean, is it that standard 72-hour?
No, because think about their circulatory system and metabolism. Yeah. The baby I took was about 6 hours old. DHS was there when they were born. Paperwork was done. PD came, and it was, I don't even know if the baby was 6 hours old when we took it, and it was already withdrawn. Yeah. So they may have a decreased level of consciousness, seizure activity, but we're not, because they're so subtle, we're not, the Versed, we're not the Narcan, we're not treating them. We really are taking care of airway, breathing, circulation, oxygenating them, ventilating them if needed, keeping them warm, and getting them to the appropriate facility. Which generally is going to be your ER, then your ER is going to ship them to the appropriate, which is probably, main med. I always try never to mention hospitals, but when you're talking about preemies or sick babies, they're going to main med or they're going to Eastern Maine. Fever. A fever over 100.4 in a newborn is a life-threatening condition. So once again, it is important to take temperatures in babies because it's hard to ascertain, is this baby 99 degrees warm or is this baby 100.4 degrees warm? They have a limited ability not only to thermoregulate when they're cold, but in the other direction. And big fevers lead them to increased use of glucose. Increased use of glucose, if they don't have adequate stores, they're going to lead to anaerobic metabolism, which is going to make the baby acidotic, which they do not tolerate that well. For fever, you may have irritability, somnolence, baby may refuse to nurse, rashes, petechia. When babies have fever and they sweat, it's only here on term newborns, and preemies won't sweat at all. Think about it. You ever seen a baby sweat? Term newborns, you'll just see a little bit of moisture on the brow. Preemies do not have the ability to sweat at all. So it's really not a good indicator of febrile. So assure adequate oxygenation, ventilation, avoid rapid cooling and cold packs on these. You may not want to keep them quite as warm, but you still want to maintain a level of warmth in them. What you don't want to do is take a baby who's got a temperature of 100.4 and drop it to 98, 97. That's bad too. I will be honest, if I had a baby that had a temperature of 100.4, newborn 100.4, 100.5, 100.1, I would call and say, how aggressively do you want me to cool this baby, and what is our target temperature for it? I would ask that question, because we're not pediatricians, we're not neonatologists. We get 8 hours of pediatric education every 3 years. This is not something that we do on a regular basis. And once again, infants cannot tolerate temperatures that are comfortable for adults. They just can't. Below 35, they are considered, or 95, very hypothermic. In these guys, they get cold sepsis in addition to warm sepsis. So an actual decrease in body temperature can also be a septic baby. Adults can get cold sepsis, but they've had it for a while. But how long has this baby in utero potentially been exposed to an infection? And once again, we already talked about things that hypothermia can lead to. So these babies may be, have acrocyanosis, early hypothermia irritable, late hypothermia lethargy, pale and cool to the touch, respiratory distress and leading to complete apnea, bradycardia. Newborns don't shiver. So important to remember, they do not have the muscle mass, the ability to shiver. You need to recognize the fact that if the environment's too cold for the baby, I haven't warmed the baby up enough, and start trying to warm the baby up. So adequate oxygenation and ventilation. You can, chest compressions if indicated, you can warm the infant. You could even think about warm oxygen. Think about a hypothermic baby. If you're giving them oxygen in the back of the ambulance, where is it coming from? Yeah, are your main tanks warm oxygen or cold oxygen? Yeah, just wrap a couple of hot packs around the supply tubing. That will give you some warm oxygen. I mean, it's not the best solution, but it's better than I've idled outside. Even, I mean, like the other morning when I went home, it was 47 degrees. If the ambulance idles outside at 15 minutes at 47 degrees, that oxygen is not all that warm. And when they will lose heat due to cold oxygen. You know, dry them, mother's body skin to skin, cover with a blanket, wear a cap. This is the other thing too. Keep, you know, how many of you guys have sat on your squad bench and felt the breeze? How many of you guys have stood in the side door and felt the breeze, right? You might want to think about covering. You might want to think about covering those windows, right? Because is air coming through there across that baby? Absolutely is. So hypoglycemia, another not uncommon thing in a newborn baby. Jitters, lethargy, respiratory distress, subtle seizures, color changes, possible apnea, limpness, eye rolling, high-pitched cry, irregular respiratory rate. So hypoglycemia can mimic hypoxemia, and some hypoglycemic babies are completely asymptomatic. So it's less than 40 for a neonate. Causes do not have to be diabetic. They can have adequate glucose stores, inadequate intake. They may be using glucose faster than they can. Stress will cause them to be hypoglycemic. Any sick infant should have a blood glucose assessment. You want to think of a sick infant as an altered infant.
Doing those from the heel?
Yep. Yeah. I mean, you can try to do it for the finger.
Yeah.
Yeah, good luck with that. But from the heel, yeah. Because that's still capillary blood you're getting down there, so yeah. Adequate oxygenation, ventilation, IV, IO with fluid, TKO. Maybe an EKG, but you want to think about the sugar first. Dextrose, like I said, D10W is what we're most used to. And keep them warm. The dose of D10W, if they're below 40 and symptomatic, is 4 mLs per kilogram. That is not very much. You can basically mix that up in a 10 cc syringe. D50, do never, ever, ever, ever give a baby
Super
D50.
narcotic.
Yeah, yeah, and you know, basically D50, I liken it to trying to push a Snickers bars through somebody's veins. That's basically what you're doing, right? Now push that through those little teeny, tiny, probably in this baby, if you got a 24 gauge IV, you are stoked, right? You're not pushing D50 through that. Do you guys have pre-mixed D10 or do you have to make it yourself?
I think there's some, there's
Free
one
meds.
hospital has it, the Bob's
There's
and
a
one
Bob's.
doesn't.
Miles med box.
So probably the easiest thing to do is draw your dose off your premix bag.
We've given it in the real frail elderly as well,
Yeah.
just because it's super.
I haven't used D50 probably now for about 5 years. I've used D10 on pretty much everybody.
I actually found the D10 on a nice drip will keep them maintained rather than
Yeah.
doing the.
Yeah, I actually, my first experience with it, we had a diabetic who was getting worse and worse and worse, and I was having to take him, 10 years ago, 15 years ago, I was signing him off once or twice a year. Now I'm going there twice a month, and I just D10 him now. I can't remember the last time I gave him D50.
What's the time frame that you would give the dose? How long?
Over how long? I don't know that it's 5, 10, 15, or 20 minutes. It would just be a really slow push. So let's say the baby weighs 5 kilos so that I can make it easy in my head. That's 20 mLs of D10. I would probably, so that's the equivalent of 2 10cc syringes. I would probably give that over about 5 to 8 minutes. Just, kind of like pushing, back when we used to push morphine, or if you do inner facilities, when you push Dilaudid and stuff, little bit. Even when I used to do D50, I would only push a little bit. So, I don't think there's a specific this many mLs over this many minutes, but it's certainly not. And I would say that not only with D10, I would say that in a newborn, fluid therapy, anything you're going to give them, because their veins are so fragile, and think how hard it is to push something through a 22. The odds are pretty good you've got a 24 in them, and that was a good day, right? So anything should probably, it would still be considered a bolus, but I would call it a slow push bolus. That's how I would term it. Vomiting in babies is rare in the first weeks of life. Spitting up is not vomiting. We use the term regurgitation because that's a nicer word, but spitting up is not vomiting. If they're vomiting, especially if it contains blood, it's life-threatening. They could have an upper digestive tract obstruction. Increased intracranial hemorrhage will cause them to vomit blood or an infection, but vomiting will lead to, or could lead to, dehydration, electrolyte imbalance, and these babies don't tolerate that well. Dehydration would be the thing that we would really want to think about. And what's a good way to assess a baby for dehydration? 3 or 4 good things that you can think of.
Depends if they've had a dry diaper.
Okay, so ask about diaper changes. How about oral mucosa? How about the crying baby who's not making any tears? Those are 3 things that can kind of give you an indicator of, do I need to do some fluid therapy? Now, in older infants, what's your fluid dose for fluid therapy? 20 mLs per kilogram, and kind of both. These guys are only getting 10 mLs per kilogram, and you're giving it over a longer period of time, because they may have an underlying congenital abnormality too that you have to think about. So you may see a distended stomach, signs of infection, signs of increased ICP. Drug withdrawal will also make these kids vomit. Think about an adult who withdraws from drugs. So make sure the airway stays patent, adequate oxygenation. Once again, what does vomiting do? Vagels babies out, so you may, or anybody else, you may want to think about bradycardia. And if you're concerned about dehydration, start a line TKO, but you can also give them 10 mLs per kilogram. Now, babies more commonly get dehydrated from diarrhea. It's a more common cause of dehydration than than vomiting. Yeah, all kinds of things could be going on. I never knew this until I started teaching this class. Persistent diarrhea in a newborn can be the early sign of cystic fibrosis. Yeah, because cystic fibrosis, we often think about it as being in the lungs, but it also significantly attacks the GI tract. So do they have decreased urinary output? Are their stools loose? Listlessness? Prolonged cap refill? How many times are they changing the diaper per day? Adequate oxygenation, temperature control, IV, and 5 to 10 mLs over 10 mLs per kilogram over 5 to 10 minutes. So these are just some statistics, something to think about, and we're gonna, this is my last slide, I'll start talkie. But birth injuries, you know, fortunately they didn't give us things like forceps and stuff, which I think is a beautiful thing. But we can inadvertently cause birth injuries. So it's avoidable and unavoidable trauma. About every 2 to 7 out of 1,000 live births have it, and 5 to 8 of every 100,000 babies die of birth trauma. 25 of every 100,000 die of anoxic injuries. 2 to 3% of infants' deaths. And the other, what's the other? I didn't put it up there, but what's the other thing that birth injuries can cause that's a lifelong disability? CP, cerebral palsy. So this is not a birthing class. This is a newborn care class, but I kind of wanted to put that up there at the end so we can think about when we're delivering babies. Take 10 seconds, breathe. The baby is probably, unless it's a crack addicted mother, baby's not coming in the 10 seconds. You need to get your heart rate down, right? I always say if you're going to these type of calls, the very first thing you should do is pick your protocol book up or look on your phone at your protocol app. That could take your heart rate from at least 160 to 140. Then I'm gonna get there, I'm gonna take 10 seconds and I'm gonna take a breath. Those 10 seconds, what they actually recommend to get your heart rate down and to get your anxiety level down is 4 times. Okay, now I've calmed myself down, because the problem is once your heart rate gets jacked up, you lose fine motor skills. Your gross motor skills stay good, but you lose your fine motor skills. Do you think this is a population you need fine motor skills with? Yeah, this is not a be clumsy, and that's kind of why I brought that up there. This is when we're not fumbling. Give yourself a couple seconds to get composed. 4 deep breaths, over 10, 12 seconds. Look at your protocols on the way there. I still, I teach this stuff, and every time I go to something pediatric or I go to something that sounds like childbirth, I'm going through the procedure in my protocols. I'm like, okay, if the baby's face down, then I'm going to deliver this shoulder, then I'm going to deliver this shoulder. Dear God, please let no crowning be happening. That's as I get to the end of it. But, you look to the right, you look to the left, somebody in this room is going to do it. It's inevitable. So. Any questions? Comments? Concerns?
Thank you for doing the
You're welcome.
whole thing.
Yes.
You're welcome.
Well, that's stuff to refresh on.
Yeah.
Now, do you suppose the cystic fibrosis is because of the same muscle that it?
Well,
like
what
that
it is
soft-
cystic fibrosis, we see it, or you hear the most about it because it's respiratory.
Right.
But it actually affects the internal organs, though that mucus collects on those internal organs and stuff too.
Okay.
Yeah. Actually didn't know that much about cystic fibrosis, but they've actually added it to the EMS class curriculums. We now, for new licensure students, for probably the last 4 years, have had to teach cystic fibrosis as one of the respiratory diseases, and it talks about the intestinal involvement. That's how I happened. Otherwise, I wouldn't have known that.
Yeah, I had no idea.
No, but it's become part of the national curriculum. And I still don't know it as good as I think I should know it, but I have an idea now. All right, if you guys have any questions or concerns, sign the roster. Please fill out an eval. And thank you for your time and attention.
Thank you.